Good afternoon, everybody. We're waiting for people to get seated. I think everyone's almost seated. Good afternoon. My name is Karen Ripper. I'm the president and CEO here at the Kane Center, the Council on Aging of Martin County at the Kane Center. Our formal name is the Council on Aging of Martin County, Inc. We're a private not-for-profit that's been in existence since 1974. We've grown from a little building in Stewart to this building in 2011. Moving into this building was intriguing in that we had a small daycare where we were and Meals on Wheels case managers, and that was it. So when we moved here, we had a lot more space and could do a lot more things. And one of the objects that we had moving into this building was to be able to provide educational resources for people in our community who need it the most, especially seniors who are going through aging transitions with all the hiccups that come along with it, and having the people to be able to partner with, to be able to provide this education and caregiver support, and also expand our programs. We can serve up to 100 people in daycare, but the pandemic has really put a crunch on all of us, as you know. So our maximum right now is about 60, so we can follow all the CDC guidelines. We have enough space for that. And Meals on Wheels hasn't missed a beat during the pandemic. In fact, our volumes went way up last year because people were shut in and didn't want to go to restaurants and so on, and it's starting to happen again. I don't have to tell you, it's a pretty tumultuous time right now in our country and worldwide with this pandemic. As a nurse, and I spent a lot of time in community health, it's pretty frightening, but we can all get through this together if everyone does their part. And I see all of you here today wearing your masks and hopefully got your vaccines and doing what you can to help stem the tide. So with that, I'd like to thank Donna True. Where's Donna? Donna is our licensed clinical social worker here at the Kane Center, and she has brought in our speakers and spent a lot of time putting this program together. We also have people online, she tells me 60 people that are participating online. So that's a great program, and hopefully you all will get a lot out of it and have a lot of good questions for our speakers as well. So with that, I'll entertain any questions. We have people resources available to you all for any questions through our care manager navigator. We have one number you call, and we're able to help people all day, every day. So thank you very much and enjoy the rest of your afternoon.
Thank you so much, Karen. Appreciate that. Hi, everybody. As Karen said, I'm Donna True. I'm a licensed clinical social worker here at the Council on Aging. I have to remember and think about there's a camera over there and you're out there, so I'm going to concentrate on both. So as Karen said, we do have additional people on Zoom. And for those on Zoom, this is a webinar, so we cannot see you. We don't have all those little boxes of people, and you don't have your microphones on. So if your dog starts barking and you're on the Zoom webinar, it's okay, we can't hear you. You can interact through the chat box. And then if you're here in person, those with questions, we have put a pen and an index card out at each table setting. And you can write your questions down and somebody from here will collect those questions so we can give them to the doctors. We're going to hold all questions for both doctors until they have both spoken. You have an agenda at your setting as well. So the session is being recorded. I want to mention something about our wonderful sponsors, because as a nonprofit agency, we absolutely couldn't survive without the support of donors. So they are resources for you as well. Before I announce them, I want to see how many seats. Each table has 4 chairs. If you only have 3 or 2 in your party and there's 2 open seats, that are not being saved for somebody, please raise your hand because we're going to utilize pretty much every chair here. Are the two, if there's empty seats at your table, and there's chairs on the sidelines as well. Any other openings in the back? There's some in the back. So Tequesta, can you see where the openings are? There's some people with an empty chair. There's one up front. There's a couple chairs. I want anybody to have a seat that there's two over on my right, so it's on your left, Tequesta, towards the front. Doctors Patel and Dalvi, you are so popular. This is great. And we really limited the in-person RSVPs too to protect everybody. Okay. Thank you, Karen. Okay. Hopefully everybody has a seat and a snack. And I'm sitting at the front table over with Laura Kramer. So if you need a snack box, you can come and see me if you're sitting on the sidelines. Don't worry, we have a few more boxes. Any more seats? Any more seats at tables? Okay. We're good. Okay, perfect. Okay, so actually today we have two platinum presenting sponsors, and you do have their literature in your bags. One is Medtronic, and they are not going to be here today. I think they might have had some surgeries or something happening today, Dr. Dalvi. They work closely with you. So we'll give you a little more information about them later, but we also have Encompass Health Rehabilitation Hospital here, and I'm looking for Melissa. Melissa, do you want to come up to the microphone and you get a minute to talk about the wonderful things that Encompass Health Rehabilitation Hospital does? And for those of you who don't know, they are right down the road from us. They are our neighbor.
Good afternoon, everyone. My name is Melissa Buckmaster, and I represent Encompass Health Rehabilitation Hospital. Encompass Health is the nation's largest rehabilitation hospital system. So we're growing. We're really growing in Florida. Our Encompass Health Martin is located right down the street here, down Salerno Road on Community Drive, right across from the library. We sit directly next to Cleveland Clinic. Our hospital is a rehabilitation hospital. We have an acute care license. And with that, we can care for patients that have had a functional decline due to an injury or illness. We have a comprehensive stroke program, Parkinson's program. Our patients are seen by physicians every day, as well as we have RNs, physical, occupational, speech therapy, and on site, we can even do dialysis. Our patients are seen by a dietitian, as well as we have a mental health provider that comes through and visits our patients as well. We have 80 beds. They're private rooms, private baths, so everyone gets their privacy. At an inpatient rehabilitation hospital, the expectations are a little higher than an acute or than a rehabilitation skilled nursing facility. So at a rehab hospital, you're expected to do about 3 hours a day of therapy. It's not consistent. It's from the time you wake up to the time you go to bed. We're going to get you out of bed. We're going to get you moving. Our goal is to get our patients back home as close to their prior level of function. So if you came in before your injury or illness, you were independent, walking, doing all of your daily care activities, we're going to try to get you back there with the therapy. So does anyone have any questions for me regarding Encompass Health? Well, thank you.
Thank you so much, Melissa. And everybody has their information on the table as well. So I also want to thank, let's see, Suzanne Moore from Elite Home Health. Can you stand up, Suzanne? So she's one of our wonderful silver sponsors who has sponsored numerous things here. Hello, Suzanne. And we also, you have her literature on the table, and Matt Green will be here a little bit later, but he is with Life Care Therapy Services. And we also have, for those of you who are brave enough to stay until the very end, after both doctors speak, we have some incredible door prizes that we will be giving out. You have to be present or have a representative present. Because we're not going to ship the baskets out, but we welcome you to stay, and hopefully you'll win a nice door prize. And I didn't bring my Dr. Dalvi intro up here. Dr. Dalvi, oh my, Dr. Arif Dalvi, he specializes in movement disorders. He is from Palm Beach Neuroscience Institute and heads St. Mary's Memory Disorder Center. And he's famous, he's well-known, he's fabulous. We love having him speak here. He knows everything and more about all the movement disorders. And I'll let him finish that up because I left my card at the table. Dr. Dalvi, take it away.
Thank you, Donna. That was actually one of the best introductions I've ever had. I think in the future, I will encourage people to forget the introductory things that they may have at the table. It works so much better that way. For those of you who don't know me, I've been in the area for about 7 years. Both Dr. Patel and I, we moved here from Chicago. She liked the weather. I just was tired of shoveling the snow in Chicago. So that's what made me come here. I started a center for Parkinson's disease focused on surgical treatments, in particular deep brain stimulation, but we have also started clinical trials of a very exciting new form of treatment called focused ultrasound that we'll talk about. This has been a tough year for everyone. This has been a tough year for medical professionals. I have 3 cousins in the area who worked frontline in medical care as physicians. And it's been a very, very stressful time for all of us. But I think it's been a very stressful time for patients with conditions like Parkinson's and Alzheimer's. These are conditions that need close evaluation, continued assessments, and it has been difficult to arrange. We have tried to some extent to work with telemedicine and the like, but especially for things like Parkinson's, we really need to see you in the office, examine you, see how you walk, get a sense that we cannot through the telemedicine technologies assess you fully. But I think it really speaks to the resilience of us all. I mean, just look at this. We're in the middle of a pandemic, but there's not only so many people here, but we have adapted technologies like Zoom so that we have an even larger audience than we normally would have arranged for in this room. So I think the resilience has been phenomenal to see on part of everyone. And I would echo what was said earlier, that if we all play a part in this by, social distancing, wearing masks, getting the vaccines, I think hopefully we might be towards the tail end of this terrible time. But I'm here to speak of more optimistic things about advances in Parkinson's, and I'm going to try our plug and pray technology to see if I can advance to the next slide. I thought this was it. Okay, that might be. There you go. That should work. So I'm going to start at the very beginning. What causes Parkinson's disease? Some years ago, I was asked by Oxford University Press to write a chapter on the etiology of Parkinson's, what causes Parkinson's. And I thought it would be, you know, a weekend's work. And I spent about 4 or 5 months researching all of those things. There are so many interesting areas to look at, but I'm going to really simplify it into 2 major areas in terms of the genes and the environment. So for a long time, people did not believe genetics had anything to do with Parkinson's. And partly this was because there was a study on veterans who had twins. And they looked at one veteran who had Parkinson's, and then they examined the other veteran for incidence of Parkinson's disease. And the idea was that if you were an identical twin with pretty much the same genetics, you would have a much higher incidence of Parkinson's in the twin than if you were a fraternal twin. But as it turns out, the concordance rate was very similar whether you were an identical twin or a fraternal twin. So for a long time, it felt that it's mainly environmental. And people looked at different things. So for example, if you live in a rural area, and especially if the water that you get is based on well water, which has exposure to pesticides, you're more likely to get Parkinson's disease. Certain compounds, toxic exposures were looked at. In particular, manganese was looked at as a risk factor for Parkinson's. Carbon monoxide poisoning can be a risk factor for Parkinson's. But when we went and analyzed this data more carefully, it turns out you're not really dealing with the same pathology in the brain as idiopathic Parkinson's, as typical Parkinson's. You're dealing more with a Parkinsonism than Parkinson's disease. Then in the 1990s, the first gene for Parkinson's was isolated. This was from a family called the Contursis. It's sort of like the family from Mario Puzo's Godfather, because some of them live in Italy and some of them live in New York and New Jersey. And this Contursi family, they looked at 400 members of the family, and 15% of them had Parkinson's disease. And it ran in an autosomal dominant fashion. They looked at the genetics of this family, and the first gene was isolated called the PARK1 mutation. We are now at about PARK 18 or PARK 22. I've lost track of where exactly we are. But this PARK1 mutation not only was the first, but gave us a lot of insights into a protein called alpha-synuclein that is felt to be a very important part of the pathophysiology of Parkinson's. And we'll talk about that in a bit. One of my mentors in New York, Susan Bressman, she had a study going on where she was looking at the Ashkenazi Jewish population. And it turned out that if you were Ashkenazi Jewish and you had Parkinson's, there was 1 chance in 3 that you had a particular mutation in a gene called as LRRK2, leucine-rich repeat kinase type 2. You're supposed to say that 3 times quickly. So leucine-rich repeat kinase type 2 mutations, 1 chance in 3 as an etiology for Parkinson's if you are of Ashkenazi Jewish ancestry. But it has also been shown in other ethnicities. So for example, North African Arabs, there's actually a 40% chance of having that exact same mutation. But since then, multiple other mutations have been isolated. There's a glucose cerebrosidase mutation that has been shown to be important. But here's the interesting thing. If you look at a clinic, even like mine, that focuses on Parkinson's, and you look at 100 people, there's only going to be about 10 of them that will have a strong family history. In 90% of cases, it's sporadic. So if you look at that figure over there, the cluster at the very top, which includes the SNCA, which is the alpha-synuclein mutation, DJ1, Parkin, they tend to be actually quite rare. And in general, there's just susceptibility variants in the genetics of a person that tend to be more common. So for the most part, the Parkinson's that we see in practice, at least to our superficial knowledge of it, is quote unquote sporadic Parkinson's. So alpha-synuclein, this was the protein encoded for by the SNCA gene, or the alpha-synuclein gene. Interestingly, alpha-synuclein is widespread throughout the body during development, but then later as development proceeds, gets confined to certain areas, particularly in the brain. But there's also alpha-synuclein that has been demonstrated in the gut. And indeed, there are some hypotheses looking at the origins of Parkinson's, starting from the gut and then going higher up through the nervous system into the brain. And also alpha-synuclein has provided us into insights similar to what we do in Alzheimer's, where we're trying to clear amyloid protein. There are approaches at trying to clear alpha-synuclein from the brain using compounds that affect the metabolism of alpha-synuclein. But also there's been initial research done in Parkinson's disease vaccines that have potential. It's going to be very interesting to see, with the COVID vaccine, the new technology, mRNA, has been used to develop the Pfizer and the BioNTech vaccine and the Moderna vaccine. And this technology has been around looking at the study of cancer, for example, but it will be interesting to see this technology applied to neurology, especially in the approach to developing vaccines for Parkinson's and Alzheimer's. So that'll be some developments that we will follow over time. So essentially what happens with alpha-synuclein is it's normally present in cells as sort of an isolated form. But because of certain genetic mutations, it starts to form clumps. And then these clumps form what are called as fibrils. And then these fibrils are deposited in the cells of the brain called the Lewy body. And we'll have occasion to talk in more detail about the Lewy body and its importance in Parkinson's as well. So interestingly enough, the genetic factors have also been looked at with respect to clinical subtypes. We have often, for a long time, divided Parkinson's patients into two types. One is tremor predominant. They have a lot of tremor. Sometimes the tremor cannot be controlled by medications. But overall, they tend to be better preserved from a cognitive standpoint, have better balance. They don't have as much in terms of autonomic features. And the second type of patient is akinetic rigid. They tend to have no tremor or almost no tremor, but they're very stiff. They're very slow. They freeze up when they walk. They have drops in blood pressure when they stand. They have much more in terms of cognitive symptoms. Interestingly enough, this group also tends to have a higher incidence of a sleep disorder called REM behavior disorder, where these patients act out their dreams. So there's interesting new work being done looking at the genetics and clinical subtypes, and they are trying to define two types of Parkinson's. One is body-first Parkinson's, which presents more with these akinetic rigid presentations. And then the second is a brain-first Parkinson's. And the body-first has been associated with the alpha-synuclein mutation, whereas the brain-first has been associated with the LRRK2 mutation. So this is important in terms of defining the patient type, but also towards projecting a prognosis for these patients. Now, one question is often asked, not just at the first visit where we might hint that somebody has Parkinson's, but the second, the third, the fifth, do I really have Parkinson's? How do you know? In fact, this was taken from the APDA website, where the patients say, all my doctor did was, watch me do some hand movements, had me walk in the corridor, and then said, hey, you have Parkinson's. And how can I believe that diagnosis? How do they know for sure? Isn't there a test? So the one thing you have to remember regarding testing in medicine is a test does not give you a diagnosis. A test does not even give you the probability of a diagnosis. A test updates the probability of diagnosis. This type of thinking in mathematics, it's called Bayesian thinking or Bayesian probability. So when you're looking at a patient population with clinically defined characteristics, you're looking to see what the clinical features are. And if the patient is presenting with these typical findings, you have a high probability a priori before a single test is done of them having Parkinson's. And then you have to look to your tests and see how much better is the probability going to be, or more accurate is the probability going to be if you do the testing. And that's what you have to keep in mind in terms of ordering these tests. So the classical symptoms, we have a mnemonic for it called TRAP. T is for tremor. Typically, it's a rest tremor. Patients with essential tremor have a lot of postural tremor. When they hold their hands up, it shakes a lot. But when their hand is by their side or when they're walking, they don't have much tremor. Rigidity, muscle stiffness. Akinesia, or it's also called bradykinesia, slowness of movement, and posture and gait changes. These are the cardinal symptoms of Parkinson's. Obviously, this is the tip of the iceberg. There's a whole range of other symptoms that present in Parkinson's. Now, if we have to make it more formal, especially, for example, if we are doing a clinical trial, we use what are called as the UK Brain Bank criteria. And I've simplified some of these for you. So step one is to look at the positive features. And interestingly enough, the defining feature in this is bradykinesia or slow movements. It is not tremor, because a good 30% of Parkinson's patients will never, ever have tremor. Even if they've had Parkinson's for 20 years, they don't have any tremor. And we talked about the akinetic rigid pattern, and that has something to do with it. But the bradykinesia should be supported by at least one of the following: muscle rigidity, a 4 to 6 hertz rest tremor, and postural instability without a secondary cause, like having had a stroke before or having some spinal cord lesion that can explain the postural instability. So that is step one. Step two is to exclude secondary etiologies. So for example, we typically will order a CT scan or an MRI of the brain, not so much to say, yes, somebody has Parkinson's, or no, somebody does not have Parkinson's, but to rule out other things like normal pressure hydrocephalus. This is where the fluid spaces in the brain, called the ventricles, they are enlarged, and the mechanism is such that it can lead to 3 main symptoms: trouble with gait or walking and balance, trouble with urinary frequency, and trouble with memory. So we want to exclude secondary etiologies. There are certain rare conditions like Wilson's disease that we exclude with blood tests in younger patients. And we try to exclude Parkinson's plus syndromes. There's a whole range of these. I once wrote a chapter on these, which is still, I think, online. If you look up Parkinson's plus syndromes, there's about 17 different types. Diffuse Lewy body disease is probably one of the more common ones. Corticobasal degeneration, progressive supranuclear palsy, multiple systems atrophy, and on and on. The big difference goes between typical Parkinson's and the atypical forms goes to the step 3 supporting criteria, which is clear-cut response to levodopa or similar medication. So the patient has to improve significantly in a noticeable manner when they're treated with levodopa or similar medications. Also helpful is the fact that it tends to be unilateral and tends to have a persistent asymmetry, which is why a lot of Parkinson's patients initially might be misdiagnosed as having had a stroke or a TIA, because it tends to be more prominent on one side. And in fact, if it is very symmetrical, you're thinking of the Parkinson's plus syndromes rather than Parkinson's disease. And there's a progressive clinical course over 10 years or more is what we are seeing. So the first slide on your left is normal pressure hydrocephalus. This is a chapter, again, I wrote that that MRI scan is from one of my patients. You're seeing the dilated ventricular spaces, and that arrow is pointing to what is called as transependymal flow, which is a feature that you see on imaging, especially on MRI imaging in these patients. The other one is taken from a patient who has Wilson's disease, and they're having structural changes in the basal ganglia that are bright on the scan. And this, again, can be tested for by blood testing and by looking at the urine for copper in the content in the urine. Wilson's disease is an abnormality of copper metabolism that results in what is called as hepatolenticular degeneration. Hepato from the liver, and lenticular because this lentiform nucleus, which you're seeing on that MRI, looks kind of like a lens, is affected with the copper deposition as well. Now, one question often comes up is, should I have a Datscan? Or sometimes I've had patients who have had a normal Datscan, but I still go on to treat them as having Parkinson's disease, because there's a tendency for Datscans to have false negatives as well as false positives. In fact, if you look at sensitivity and specificity of these Datscans, it's about 90% in patients who have a strong likelihood of having Parkinson's disease when they're examined clinically. What Datscan does is it uses a radioisotope, which is an analog of cocaine, because cocaine binds to the dopamine transporter in the brain, which is why people who are addicts get a surge of dopamine, and that is part of that addiction mechanism. Now, this Datscan is not going to make you addicted. It's not going to give you a dopamine surge, but it uses the same receptor to attach to. And let's say you have essential tremor and you have terrible tremor, but because it has nothing to do with the dopamine metabolism, your Datscan is going to be normal. It's going to show more like a comma-shaped distribution. Whereas if you have Parkinson's, there's going to be lack of uptake, and it becomes more like a period-shaped distribution rather than a comma-shaped distribution. One issue with Datscan imaging is that it does not distinguish Parkinson's disease from the atypical forms. If it did that, it would have much more value. Coming back to the Bayesian modality of thinking, if you're looking at a clinical diagnosis that is 80 to 85% accurate, and you're adding Datscan imaging that costs around $5,000 typically out of pocket, and you're changing that 80 to 85% accuracy to 87 to 89% accuracy, you're not really adding much. It's not a great value proposition. So in my own practice, I do not rely so much on Datscan as much as on clinical diagnosis, and then offering them a trial of levodopa or similar medications and looking to see if the predicted response is there or not. If there are diagnostic uncertainties, then certainly Datscan can be a valuable test. So what sort of diagnostic uncertainties does Datscan help with? If you don't have a clear-cut response to levodopa, or if there's a mixed diagnosis, there are some patients who have essential tremor for 10, 15 years and then develop superimposed Parkinson's disease signs. Sometimes it can be helpful in that context. Some patients will have Parkinson's, but will also have normal pressure hydrocephalus findings on imaging. And in these patients, it can be somewhat helpful. In young onset Parkinson's, if somebody is in their 40s or 50s and there's a question of Parkinson's, Datscan can be helpful. But unfortunately, the main reason why it would have been helpful would be to distinguish typical from atypical, and it does not do that. So if you have a classical clinical presentation, if you have an excellent response to levodopa, you really do not need a Datscan. So how does levodopa work? Because that is the mainstay of treatment of Parkinson's even in 2021. So if you look at the midbrain and you do an autopsy and you look at normal brain versus Parkinson's, in the normal brain, you see that dark line going across that is called a substantia nigra. In the Parkinson's brain, it has lost that dark pigmentation. And the reason it has lost that dark pigmentation is there's not enough melanin in that area. Now, what does melanin have to do with Parkinson's? It's because melanin is a metabolite of dopamine. So what it is really reflecting is a lack of dopamine in the brain. The microscopic slide is actually showing Lewy bodies in the brain. Again, you can see brownish pigmentation of melanin in those cells, but those pinkish blobs in those cells are the Lewy bodies. And these days, we're looking at disease states from a molecular standpoint. And what we are finding, one of the major contents of the Lewy body is alpha-synuclein. So again, genetics, explaining proteins, explaining pathology, explaining macroscopic pathology, explaining disease state. That's how we are analyzing these conditions. So again, this is just to show metabolism of L-Dopa, which is converted into dopamine. There's there is an enzyme called dopa decarboxylase that is responsible for this conversion. And when initially levodopa was developed in the 1950s, there was a hypothesis that it might be helpful for Parkinson's, but it was almost given up on because it would be broken down by peripheral dopa decarboxylase outside of the brain into dopamine, and then it would hit receptors in the gut and cause terrible nausea. So people said, you know, maybe this drug works, but no patient can even tolerate it. And then Cotsius came up with the idea of using dopa decarboxylase, which means you can use much less levodopa for the same clinical effect. So combined, it's called carbidopa levodopa. So it's very rare that we give levodopa by itself. It's always combined with carbidopa. In fact, when you combine carbidopa with levodopa, the brand name is Sinemet, and that's a very clever name. Sin in Latin means without. Emet comes from emesis or vomiting, so without vomiting. That's the idea behind using Sinemet as opposed to levodopa alone. But again, there's a parallel pathway whereby levodopa can be broken down into melanin, which is why in the substantia nigra in Parkinson's patients, you see the pale area rather than the dark pigmented area. Now, what does lack of dopamine do? According to somebody on Oprah, which is where I get all my medical information, dopamine is like motor oil for the brain. And actually, that's a very nice way of putting it, because if you don't put oil in your engine in your car, it's going to freeze up. It's going to be slow. It's going to be sluggish. The motor is not going to run well. The way it works in the brain is lack of dopamine in the brain affects electrical signaling pathways in the brain. In fact, when I'm in the operating room doing the brain mapping, we can actually identify certain areas of the brain are overactive, way too active than they need to be, and other areas are underactive. And again, this is because of lack of dopamine. In fact, when we are doing the procedure, we'll tell the patients that don't take any levodopa or Parkinson's medications from 9 p.m. onwards, because we want to see what the brain is doing without the dopamine while we're doing these 2-3 hours of brain mapping. And this allows us to understand the electrical circuitry in the brain. These two pathways are called the direct and indirect pathways. And when I used to be a professor, I used to love to torture medical students and residents by explaining all the paths and what neurochemical is released. But at its simplest, when you have low levels of dopamine, a part of the brain called as the subthalamic nucleus becomes overactive, and that in turn makes the globus pallidus internal segment overactive, and that acts as a brake on your motor system. So that is why you slow down. That is why you're shuffling. That is why you're rigid, because of that overactivity. So part of what we do in deep brain stimulation, which is why we target the subthalamic nucleus or the globus pallidus, is we put an electrode there and we shut down that excessive activity, which is why we help not only tremor, but we also help rigidity and muscle stiffness and the on-off fluctuations with deep brain stimulation. One big issue is, while we know levodopa is still the gold standard, one issue is the off state. So there are patients who look completely normal at 8 o'clock after having taken their 7:30 tablet, but when it comes 11 o'clock, they suddenly shut down. They go from an off to an on state. In fact, the person to come up with this was Stanley Fan, who was my professor at Columbia. He described this on-off fluctuation, and he would show us movies. Actually, in those days, they didn't have iPhones. They had these huge movie cameras, and they had these things on reels, and then they would break down, and he would stick them with some tape, and then they would show us the tapes, and you would see somebody who is walking, talking normally, and when the levodopa wears off, they become stiff and rigid and slow. And even today, that's what we will see as the disease state progresses. You go from having a good, sustained, smooth response to having on-off fluctuations. So this is what it looks like in the early stages. If you look at it, most of that curve is in that green area, which is in the good on state. When the patient is functional, they're able to do the things they need to do. But as the years go by, that duration becomes shorter and shorter. Not only that, you hit the peaks on that yellow side, which is the dyskinesias, the involuntary movements that you get. And on the trough side of things, you're getting off-state symptoms. Either you might have a delayed onset of the medication, or the medication might not kick in at all in the form of a dose failure. Oftentimes, patients will have a morning akinesia before they take their medication, or even after they've taken their medication, because it takes about an hour for it to kick in. They might really struggle with that first hour of the day. That's called a morning akinesia. So predictable end of dose, morning akinesia, dose failure, sudden off states, dyskinesias, off dystonias are all types of motor fluctuations that you will see as the disease progresses. The mechanisms for this, one mechanism is thought to be pulse style stimulation of dopamine receptors. In the normal brain, dopamine receptors are exposed to a steady diet of dopamine. It's more or less continuous. But with the medications, when we give levodopa, there's a surge of dopamine and then nothing until the next dose. So this pulse style dopamine stimulation actually changes receptor sensitivities, which then leads to on-off fluctuations. There's also, over time, the natural dopamine producing cells continue to die out. And so the storage capacity, when we give levodopa from the outside, it's actually stored in these neurons. But as these neurons die out, the storage capacity is lost. So the graph that you see in terms of the pharmacokinetics, the levels in the blood, becomes the graph in terms of clinical features, the on-off features that we see. There's also the gut plays a role, because if you have a high protein diet, the protein is broken down into amino acids, and there's a transporter in the gut that picks up the amino acids and brings it to the bloodstream, which then goes on to the brain in the case of levodopa. That same transporter picks up the levodopa. So too many people at the bus stop, the levodopa gets left behind, and that's can be a mechanism for dose failure. So one new methodology or new medication that has been developed in the last few years is inhaled levodopa. It's also called Inbrija. So the idea is, instead of going through the gut where it's subject to protein in the diet and other issues with gastroparesis, slow bowel movements and the like, this is going from the lungs into the bloodstream to the brain. So you're bypassing the gut altogether. And in the clinical trials, it was shown that within 10 minutes, there's an onset of action. And by 30 minutes, there's a clear difference between the inhaled levodopa versus placebo. But then it starts to wear off at about 60 to 90 minutes. So this can be a good rescue medication. This can be a good bridge medication. I've prescribed it to patients who have morning akinesia so that they can have a jump start to their day. The one issue with it is it is inhaled. So some patients, the powder can stick to the back of their throat and they can have some coughing episodes with it. What I tell them to do is you're supposed to take 2 puffs with each treatment. I have them take sips of water before, sips of water in between puffs, and sips of water after the puffs to allow for less coughing and similar irritation. So Inbrija has been very helpful to a number of patients as a rescue medication. It does not replace the carbidopa, levodopa, or other medications a patient may be taking by mouth, but it's a good rescue medication. Similar concept is Kynmobi. We used to have and still have an injectable called apomorphine, which is under the brand name of Apokin. But a lot of patients, somehow they start the Apokin, and even though they find it effective, the thought of having to take 3 to 4 injections every day often has not been sustainable. So this is a way to deliver the same apomorphine through a strip that is sort of like the Listerine strip you might get. It's very similar in nature. You put it underneath your tongue. It's sublingual, and it's absorbed from the mucosa and goes into the bloodstream and goes to the brain, again, bypassing the gut to a large extent. And again, it is used as a rescue medication. One thing I would clarify, even though it's called apomorphine, it has nothing whatsoever to do with morphine. So it's not addictive. It's not going to put you on the path to the opioid crisis. It's a chemical structure that resembles morphine, but does not cause addictive behaviors or anything of that sort. Again, very quick acting. The onset is within 30 minutes, and the effect continues for about 90 minutes with this medication. The one downside to this is, unlike Inbrija, which is really levodopa, this is a different compound. It works on the postsynaptic dopamine receptors, and some of it is hitting the receptors in the gut and other areas. And so nausea can be a side effect, and also drops in blood pressure. So I try to initiate, whether it is Apokin injections or whether it's Kynmobi, I try to initiate the first doses in the office. So I'll have patients come in, we'll have a representative from Kynmobi come in, and we're monitoring your blood pressure sitting and standing for about an hour, make sure you tolerate it well and you're under our observation and supervision. We sometimes will also have a home nurse go in to do the initiation visit, so that is a possibility as well. But you have to be a little careful to make sure that patients with already running low blood pressures or already needing medications for autonomic insufficiency, they probably don't make the best candidates for this medication. Now, another question is, you've been diagnosed with Parkinson's. How is it going to progress? What should you expect in the next 10 years or so? So this is sort of the various ways in which symptomatology progresses. If you look at the 0 time point, it's about 10 to 15 years away from when the Lewy body pathology is first noted in the brain. And the first symptoms might be something like change in sense of smell, or it might be something like constipation, can be even a predictor of Parkinson's. Later on, you will have sleep disorder, so REM behavior disorder. In most people, when we sleep and we are dreaming, we're in a state of paralysis. It's called REM atonia. But Parkinson's patients, they might lose that REM atonia. So when they are giving a blow to the villain in their dream, their spouse next door is getting a black eye in the morning. And it's not uncommon at all, this story. Again, the other symptoms that you can see are depression can be a feature that you will see with Parkinson's patients, even many years before they're formally diagnosed. And then they start to see the motor symptoms, the trap symptoms, tremor, rigidity, akinesia, posture, and gait changes. And then over time, over another 10 to 15 years, there's further progression. And unfortunately, this further progression can include the thinking areas of the brain. So Parkinson's related dementia can be part of the presentation as well. A question is often asked, do I have Lewy body dementia or do I have Parkinson's with dementia? To some extent, it's arbitrary. It's worth remembering that Parkinson's disease is also a Lewy body state. The difference is in diffuse Lewy body disease, the presence of the Lewy bodies in the thinking areas, cortex and other areas is much earlier. Arbitrarily, we say that if you have cognitive symptoms, memory issues, hallucinations within the first year of diagnosis, we would say you have diffuse Lewy body disease. Whereas if you had more long-standing motor symptoms first and now are developing cognitive symptoms, we say you have Parkinson's disease and Parkinson's disease associated dementia. So we really have to manage patients. We have to manage the symptoms. So to some extent, it is a semantic distinction rather than a true distinction. One idea or one approach to studying the progression of Parkinson's has been by Braak, who has described what is called as Braak pathological staging. And what they have demonstrated in their research is, again, Parkinson's starts in the brain many, many years before diagnosis. It can start in the olfactory cortex, which is the sense of smell being affected. And then gradually it starts to reach higher areas. So by the time it reaches the substantia nigra, which is where the dopamine is produced, it can take 10 to 15 years based on these Lewy body studies. And then again, another 10 to 15 years before it spreads to the cortical areas, the neocortex and other areas. So this has given us a lot of insights. It is not the only explanation because there are some forms of Parkinson's disease like those associated with the Parkin mutation where the Lewy body might not be a presentation. And in fact, these patients present often with young onset Parkinson's. The youngest I've diagnosed was age 17 when I diagnosed her, and she had a Parkinson mutation. But for a lot of Parkinson's disease progressions, this Braak pathological staging has allowed us to correlate clinical symptoms with disease progression. So coming to deep brain stimulation, you've tried medications, you've tried rescue medications, you've tried dose adjustments, but you're not getting adequate control. And that's when you start to think about surgery. So the lay press calls deep brain stimulation a pacemaker for the brain. And I really like that description because if you look at heart arrhythmias, you have abnormal signaling in the circuits of the heart. You put an electrode in, connect it to a pacemaker and bring the electrical signaling of the heart closer to normal. That's precisely what we are trying to do in the brain. As I mentioned, I do the brain mapping in the operating room, and we can actually identify these abnormalities, and that helps us target the electrodes to that area in the brain. So one thing to keep in mind is disease progression and deep brain stimulation. If you look at those gray dots, you're looking at typical Parkinson's. So it doesn't go downhill in a straight line. There's a honeymoon period of 8-10 years where you are on medications, a little increase in medication at this visit, a little decrease in medication at that visit, but more or less you're doing reasonably well, you're doing what you need to do. And then there's a more accelerated phase. And this is where you start to have a lot of on-off fluctuations, dyskinesias, and the like. And then finally, the last 2 or 3 years can be a much more rapid progression, especially as the cognitive symptoms set in. So really, there's 3 steps in the progression. What we are trying to do with deep brain stimulation is we don't offer it to you when you're in the honeymoon phase. Why would we offer brain surgery when all you needed is an extra levodopa tablet in the day? But once you start to have random fluctuations, once your quality of life is being affected, no matter what medical trick we bring out of our bag, that's when you start to think about surgical treatment, and it has the potential to really change the slope of the curve. The 0 to 100 that you're seeing is the Schwab in England activities of daily living scale. At around the 50% mark is where you start to become dependent on others for your day-to-day activities. So what we're trying to do with deep brain stimulation is keep you above that dependence mark. So even though you will have progression, it is going to be slower than if you did not have the surgery. So if you look at when to time the stage of the surgery, obviously not prodromal, you haven't even been diagnosed yet. In the early years, you have some bradykinesia, rigidity, tremor, but the symptoms are reasonably well controlled by medications. You can learn about DBS, you can read about it, but there's no real thought process that you will need it in the next year or next 2 years and so on. But once you reach mid-stage with a lot of fluctuations, with a lot of dyskinesias, inadequate control of symptoms, poor quality of life, that's when you have to give serious thought, read about it, discuss it with your physicians, risks as well as benefits, and then make a decision. One thing we like to do is we have patients, and I absolutely am not going to put them on the spot, even though I can see they're in the audience. We have patients who have had deep brain stimulation surgery act as ambassadors, because it is hard for somebody to say, I'm going to have a borehole, I'm going to have an electrode, and I'm going to have a pacemaker, and I'm going to go through this complicated surgery for my Parkinson's. So what we encourage patients to do is, some patients who have had the surgery at our center, they're kind enough to take a call from patients who are planning the procedure and have a heart-to-heart discussion as to how they made their decision with regard to deep brain stimulation and their experience. And we encourage those patient ambassadors to give the whole story, good, bad, ugly, and all of it, so that the patient at the other end can make a good informed decision. But the one thing that we don't want to offer DBS patients to is the late stage. Oftentimes, especially neurologists will keep their patients until the very end and then say, hey, go see Dr. Dalvi, he might offer you DBS. But these are patients whose Parkinson's advanced well beyond where DBS is going to be effective clinically, let alone in terms of slowing disease progression. So that mid stage is where you need to think about deep brain stimulation. I had occasion before this terrible pandemic to speak at a movement disorders meeting in Nice, and I spoke to one of my colleagues over there. We were co-presenting on deep brain stimulation, and her group at Grenoble is actually one of the pioneers of deep brain stimulation. In fact, the person who came up first with the hardware is a neurosurgeon by the name of Alim Benabid out of Grenoble, and his group has the longest experience with regard to deep brain stimulation. And they published a paper recently in Neurology, which looks at long-term follow-up. We're talking about 15 years plus in these patients. And what you're seeing is, even at the 15-year mark, in terms of the physical symptoms in particular, if you look at dyskinesias, if you look at motor fluctuations, there's a remarkable continued improvement with deep brain stimulation. Now, if you look at quality of life, it is still improved by about 13% or so, not as much as it would be, say, in the first 5 to 7 years of treatment. So you might ask, why, if the physical symptoms are still so much well controlled, is the patient saying, my quality of life is better only by about 13 to 15%. And the reason is the cognitive issues, because if there's cognitive decline, memory issues and the like, obviously it affects quality of life. Deep brain stimulation will not improve those cognitive parameters, except indirectly, in the sense that if you're able to cut back medications for Parkinson's after DBS, which we often are able to do, less medications means less slowing down of the brain, a better functioning brain in terms of cognitive areas as well. So this is now a very nice publication looking at not just DBS for a year or 3 years, but a good 15-year experience with one of the most experienced groups in the world that has published this. Now, if you look at your iPhone or your Android phone, what you have today is very different from what it was 10 years ago. Even though it's still called the iPhone, the technology behind it has improved dramatically. Same goes for deep brain stimulation. We have improved our imaging techniques. We've improved our brain mapping techniques. In fact, I use a technique called as Ben's gun, named after none other than Alim Benabid, because before the surgery would take us 7 or 8 hours because we would track one area of the brain, then spend time repositioning the electrodes, putting it in another area of the brain, then doing another area separately. Now with this Ben's gun technique, we're able to do 3 tracks simultaneously, and this dramatically speeds up the brain mapping time required, and it cuts it down from 6 or 7 hours to 2 or 3 hours, sometimes 4. So that has been an improvement in the technique. The battery life that we offer these days with the devices is better. The pacemakers are thinner. Medtronic, which is one of our sponsors, they have developed a technology called BrainSense technology that records from the brain itself. We also have directional electrodes that allow us to steer the current in different ways if patients are having side effects. So deep brain stimulation still is gold standard surgical treatment for Parkinson's. It is FDA approved. In fact, it was first FDA approved in 1997. And it is covered by Medicare and by a number of insurances as well. So insurance in itself should not be a reason for you not to have deep brain stimulation surgery. Now, I mentioned earlier, we are researching a new technology called focused ultrasound. So I'll tell you a little bit about that. So the full nomenclature is MRI-guided focused ultrasound. It has been approved for essential tremor. It has been approved for Parkinson's disease tremor. It's a non-invasive surgical option. So you don't even go to the operating room for this. It is done in an MRI suite, and there's no pacemaker that is required. There's no electrode going into your brain. You do make a small stroke-like lesion over the course of 3 to 4 hours. And all this time you're awake, we are examining you for the tremor, we are examining you for side effects, and little by little the lesion is built up to where you have good tremor control and avoiding side effects. The one reason why, even though it is FDA approved for Parkinson's tremor, I would not recommend it to you as it is because the target that has been approved is called the thalamus in the brain. It is a good target for tremor control, but unfortunately in Parkinson's patients, unlike essential tremor patients, it can make your gait and balance worse. It can give you some trouble with speech dysarthrias and the like, which is why we are doing a clinical trial with focused ultrasound for Parkinson's specific symptoms, and I'll tell you a bit about those trials. If you're on a blood thinner of any kind other than aspirin, Plavix, if you're on anticoagulants, you cannot have this because, again, we're building a stroke in the brain and we don't want it becoming a large bleed in your brain. So blood thinners are a contraindication. There are certain technical challenges based on your skull thickness that we can do the procedure in certain patients, but not in the others. So if you're too thick-headed or too thin-headed, we don't like to do this surgery. So this is what it looks like during the procedure. We are standing on the one side of the screen. The patient is in an MRI scanner on the other side. We're using this technology to map the brain in the X, Y, and Z axis. We're defining the target. And on the other image, you're seeing this white blob over there, which is basically pointing to the finished target, which is a lesion in the thalamus that you're seeing towards the midline. You can see that white blob. And that is really the completed lesion, and this patient had excellent tremor control following this procedure. So we already have completed enrollment for PD006, which was sponsored by Incytec. We are actually the #1 recruiter in the world, and we are competing with centers like Stanford and UPenn for this trial. So we were very fortunate that we were able to get this up and running and offer it to so many patients in our area. The target in the brain is not the thalamus, it's the globus pallidus, and we were only doing lesions on one side of the brain in patients who have motor fluctuations and dyskinesias. And we are following these patients over 5 years because we're interested in knowing not just how they did for the first year, but what the long-term response is going to be. And again, this is carried out under Palm Beach Neuroscience Institute, but we have a number of other collaborators in this trial as well. We have already gathered the first year data that has been submitted to the FDA, and hopefully we should hear a word from them in the not too distant future. But again, the issue is, can you do it on both sides of the brain? And we know from our prior experience with pallidotomy that the target that we chose is not ideal for doing both sides of the brain. So we have refined the target, and we are now going to actually actively enroll patients in a new trial offering surgery for both sides of the brain. And I'll tell you about that in just a bit. But one question is, in patients who are considering surgical treatment, should I have MRI guided focused ultrasound or should I have DBS? If you look at the experience with DBS, 20 years plus experience, over 100,000 Parkinson's essential tremor patients treated throughout the world. My own experience, I stopped counting at around 500, but now I'm sure I'm around 1,000 patients over the years. So there's a lot of experience with deep brain stimulation. With MRI guided focused ultrasound, we only have about 2 years of published data, only about 200 cases. So we're still learning about this technology and the best ways to use it. One advantage to DBS is, in addition to the MRI, which gives us a lot of accuracy in terms of pinpointing the lesion, but with DBS, we also do brain mapping, which really improves the accuracy by another 2 to 4 millimeters. Doesn't sound like much, but can make a huge difference in terms of improvements, in terms of avoiding side effects, in terms of increasing battery life, and so on. One big plus with DBS is it's reversible. If you're having numbness in your face, if your face is drawing up, if you're having pins and needles in your hands, you turn the DBS device off and you're back to baseline. With focused ultrasound, if you have side effects, these tend to be longer lasting. It's not reversible. There's no device that you can turn off. A big plus with focused ultrasound, though, is no hardware. So it's sort of a one and done procedure. There's no programming, no adjustments required, which can be both good and bad. So in essence, they have their advantages and disadvantages. Come to us, talk to us, we'll help you make the choice. Some patients are much better suited for focused ultrasound. Some patients are much better suited for deep brain stimulation. One thing to remember is, if you have MRI guided ultrasound, and let's say 3 to 5 years down the road, the effect of that is fading, we can offer you DBS at that point. But if you had DBS today, because now you have a pacemaker in you, you cannot have the MRI guided focused ultrasound. So that sequencing also is something to be kept in mind as this technology becomes more available. So PD-014 is our upcoming clinical trial, again, sponsored by Incytec. We are going to begin enrollment in 2 to 3 months. This is going to be offered for both sides of the brain, but it's going to be done in a staged fashion. So you'll have one side of the brain done first, and then 2 to 3 months later, you'll have the second side done. The target in the brain is the pallidothalamic tract as opposed to the globus pallidus, so less associated with the risk of side effects like dysarthria or visual field deficits. Again, if you are not satisfied with your medication treatment, talk to us about deep brain stimulation, whether you have motor fluctuations, dyskinesias, or tremor. So talk to us about surgical treatments, and we will see whether you fit the criteria for PD-014 or whether you would be better served for deep brain stimulation. Both are reasonable options based on your specific symptoms and signs, and based on other comorbidities you may have, the technical challenges I mentioned. So again, the good news is we are really continuing to increase the options we have available to treat Parkinson's, and have continued to do that all through this pandemic time. If you need more information, pbni.com, you can see some of our information over there. You can also set up appointments directly through pbni.com, and then there's also the phone number up there if you guys want to note it down. I've been told not to solicit questions right now, but to have Dr. Patel present her part first, and then we'll take questions together towards the end. But thank you all for your attention. You've been a great audience.
Thank you so much. Dr. Dalvi, I know I learned a lot. Now I know I can say Dr. and Professor Dalvi. I was listening to what you did in the past too. And Dr. Patel, I didn't know if you wanted to stay where you are seated or, okay, if you prefer to sit, that's, you just have to turn it on. There's a button on top. You just press it down. But I'll do your, I do have your introduction.
Testing.
There you go. Now she has the clicker. Okay. So again, I learned a lot and I hope everybody checked out the snacks on their table. So I don't know if the boxes have been opened, but there are some snacks in there to get you a little dessert. Also, we're not taking an official break. So if you do need to use the ladies or men's rooms, they're right outside those double doors. Might be because yours is on at the same time. Sorry about that. We just want to make sure everybody was awake. That's all. It worked, didn't it? Okay. And before our volunteers leave, I don't know, there's still some in the room, but we had some fabulous volunteers who really helped us out. We couldn't have done today without our fabulous volunteers. I see Tara walking with some water, and I see Karen in the back, and I think Carol left, and we had Dulcie here, and we had Patty here. So we thank them because they set everything up for us. And we also thank Adam for the Zoom and doing all this. Okay, Dr. Patel. She is a neurologist specializing in cognitive disorders, including dementia and neuropsychiatry. Prior to joining Brain Matters Research, Dr. Patel completed her fellowship in cognitive behavioral neurology at the Cognitive Neurology and Alzheimer's Disease Center at the Northwestern University Feinberg School of Medicine in Chicago, Illinois. She conducted her residency in neurology and internship at University of Illinois College of Medicine, Peoria, OSF St. Francis Medical Center, located in Peoria, Illinois. She earned her medical degree at Ross University of Medicine in Rousseau, Dominica, West Indies. She has been practicing medicine since 2008, and we are absolutely delighted. We are absolutely delighted to have Dr. Patel here today. Dr. Patel.
Thank you, Donna.
These are handy wipes. Yeah.
That's perfect. Thank you.
It's gonna be wet now.
Thank you so much. Thank you so much, Donna, for that warm welcome. And thank you to you and Karen Ripper for having me here today. It's my pleasure to be here. And thank you to our audience, both here and at home, tuning in to my presentation today. I promise I will try to keep it short and sweet because I see all these wonderful goodies sitting at the front of the stage that are waiting to be handed away. But without further ado, I'm going to talk about navigating through memory loss as well as advances in Alzheimer's specifically. I currently work at Brain Matters Research. We are located in Delray Beach as well as up here next to the day clinic. We are blessed to have Donna, Karen, and all the resources here at the Kane Center to help support the care that, that dementia involves. We know that dementia is a complex process, and it's not possible for our caregivers to care for our patients alone without supportive resources like these. So we are very grateful. So today, I just wanted to mention that I have no pertinent financial disclosures. And just to take you through a framework of what we'll discuss today, my goals today are to take you through diagnosis, through treatment options in Alzheimer's that involve both symptomatic therapies that are already available as FDA-approved therapies, as well as a newer disease-modifying therapy called Aduhelm, which some of you may have heard of, that was approved recently, as well as options to other disease-modifying therapies through clinical research through sites like ours at Brain Matters Research. In terms of diagnosis, key points that I would like you to take away from today are differentiating age-appropriate changes from mild cognitive impairment, and then taking it one step further and even differentiating that from dementia. So just by a show of hands, how many of you here are wondering today what the difference is between Alzheimer's and dementia? That's just about what I expected. So we will talk about that, and I will clear up some confusion, and you will hopefully walk away with a crystal clear image of what the differences are between those two. So starting off with age-appropriate changes, some of you may have noticed this within yourself or within other people around you, and they can include things like slower thinking, what we call tip of the tongue phenomenon, where you might have some difficulty retrieving a name or some information, and then that information comes to you later on. That's not necessarily abnormal. It could be considered age-appropriate. In fact, it's a common phenomenon after the age of 65 or around the age of 65. So don't worry, you're not alone. There are plenty of other seniors out there having the same difficulties. There are also a decline in multitasking abilities and focus. So, you know, some of you may have noticed you decided you went to go and put laundry in the laundry machine, and you started to walk towards the laundry room and you forgot what you were doing or why you ended up there. And that could be normal too. Making bad decisions once in a while also could be normal. Misplacing items from time to time also could be normal. And making occasional errors with finances, balancing a checkbook, making one bill payment late on time, that could be normal too. So then what is abnormal, and when do we pursue a diagnosis? Abnormal would be when cognitive function starts to affect your daily abilities and your abilities to complete tasks. It could be complete or partial loss of memory for recent conversations or events. It could be safety issues in which we've got noticeable concerns while you are driving, or you are being scammed, or you're having repeated missed bill payments. It could also involve personality changes or sudden episodes of confusion. It can also involve difficulty actually having a conversation as opposed to just some retrieval difficulties of information or words. So when you're thinking, hey, something's going on and this doesn't seem exactly normal, what do I do? You know, it never hurts to speak to your medical provider to see if you need to have a basic memory screen done through one of our screening measures, like a mini mental status exam or a Montreal cognitive assessment. Both of these measures take about 10 to 15 minutes to perform. And some primary care providers will perform those measures in their office, or they may say you need to see a neurologist. In an ideal world, I think the diagnosis would be made through a multidisciplinary team through a memory center. Unfortunately, we don't have a memory center very close to us. I suppose University of Miami may have this type of a team. And Mayo Clinic, of course, which is a drive away, would have this kind of a team. But this team consists of a neurologist, usually a licensed care social worker, and a neuropsychologist for formal cognitive testing. Unfortunately, in this area, you may be stuck with an outpatient neurologist, perhaps if you're lucky, one specializing in memory disorders, and then you may be referred to community resources like the Kane Center or Alzheimer's Care Research Center for additional social care type of support. So key elements when you go in to get a diagnosis, what is a neurologist going to do? What is this team going to do? First of all, most importantly, they are going to take a detailed medical and social history from both you and somebody who knows you very well. This person should be able to comment on how you're doing on the onset of the memory changes, the character, and by onset, I mean, did these changes just come on suddenly one day? Did they come on kind of gradually? How did they progress? Did they progress in a gradual progressive manner, which would be consistent with something like Alzheimer's? Or were they stepwise, for example, where you had clear periods of worsening followed by stabilization, such as what we see in vascular dementia and cognitive impairment? So clinical history is very important. And I would say the clinical history by itself, if performed at a memory center, performed by somebody specializing in memory disorders, should have a 93% sensitivity in terms of being able to make a diagnosis. And then adding on things like the biomarkers, which we'll talk about later on, can obviously really help us to hone in on a diagnosis. So other things that we want to try to do during this workup process, as Dr. Dalvi mentioned, we do MRI scans and we do CAT scans, and we do these things to rule out other types of causes besides Alzheimer's. These things include normal pressure hydrocephalus, as he mentioned. They also include benign cysts and tumors that could be correctable. We are looking for correctable causes, but then we're also looking for vascular changes that can cause vascular types of cognitive impairment and dementia. And we're also looking for patterns of atrophy or shrinkage of the brain that can be suggestive of certain processes. And so that's really important. We are also very importantly looking for treatable causes, which could include medications, not through imaging, but this is through history. And we're also looking for presence of mood and sleep disorders as well, because again, things like sleep apnea can cause changes in our abilities cognitively, such as information retrieval. And sleep apnea is correctable. And so we really ought to address factors that are correctable. And sometimes we have multiple etiologies for the cognitive changes, and it could be Alzheimer's plus treatable etiologies. But we want to make sure that we maximize cognition and functioning as best as possible. And we do this by honing in on a correct diagnosis and honing in on treatable diagnoses that can help improve function. Physical exam and neurological exam are also important. These can point to other causes. So for example, signs of Parkinsonism might make me think Lewy body disease, which Dr. Dalvi, of course, deals with on a daily basis. And can also point to other types of diagnoses, including vascular dementia through gait examination and so forth. We also check blood work. Again, we are looking for vitamin deficiencies, thyroid disorders, common correctable causes of cognitive changes. And then most likely you would be referred for formal neuropsychological testing. And that's a big old fancy word for formal cognitive and memory testing through a neuropsychologist who is trained in administering and interpreting cognitive testing. And so that's pretty much the workup and the key pieces of the puzzle. And so once we have information on these pieces of the puzzle, a neurologist would take these and put them together and hopefully come up with the correct diagnosis. And they're going to either say, hey, your changes are age appropriate, or your changes are consistent with mild cognitive impairment, or they're going to put you somewhere on the spectrum that we're going to talk about of Alzheimer's disease. I hope this is big enough for everybody to see, but you're going to see there are two different lines there. The x-axis demonstrates elevated markers of degeneration, time, and the y-axis demonstrates cognitive function. The normal clinical course of normal aging is the top line that you see, where you see a pretty flat curve, and then you see something like a little bit of a drop. The bottom line is demonstrating the continuum of Alzheimer's disease. And if you notice the dotted line there, the vertical dotted line, that is separating preclinical from the rest of the stages of Alzheimer's. And when I say preclinical, I mean preclinical asymptomatic stages of Alzheimer's, because just like in Parkinson's, we know that pathological changes in Alzheimer's begin years before symptom onset. And most recent studies are indicating this could be up to 20 years in advance that we may see amyloid plaque deposition in the brain, one of the biomarkers of Alzheimer's, which we will discuss in just a few minutes. So from preclinical stage, we move on into the prodromal or the mild cognitive impairment stage, which can last roughly around 10 years, sometimes longer. And some patients will progress to dementia, and we'll talk about the differences in just a moment. So again, this slide depicts the continuum of Alzheimer's disease, starting with preclinical or asymptomatic stage. It moves on to describe mild cognitive impairment of Alzheimer's. Mild cognitive impairment is basically cognitive or memory changes associated with very mild or minimal daily functional impairment. Then we move on to mild, moderate, and severe dementia. And the biggest differences between dementia and mild cognitive impairment is the level of daily functional impairment. When you start to get into the mild Alzheimer's range, you start to require more assistance, more prompts for various things, more nudges from your partner in terms of making sure that bill is paid, or more redirection when you're driving in terms of driving directions. But the level of assistance required increases throughout that spectrum from mild to severe Alzheimer's dementia. So important to remember, again, I can't stress this enough, Alzheimer's begins before dementia. The process pathologically begins years in advance. So this is why it's very important, if you have any concern about memory and thinking, to at least talk to your medical provider, because we may be able to make an early diagnosis. In some cases, we have opportunities through Brain Matters research, for example, where we are able to identify risk factors for Alzheimer's and to be able to offer disease-modifying treatments through preventative studies that look to reduce amyloid plaque and so forth in the brain in order to help prevent or delay onset of symptoms. Also very important. So it's important to note that when we go from the mild cognitive impairment to the dementia stage of this continuum, 1/3 of individuals with mild cognitive impairment will develop Alzheimer's dementia within 5 years. But there are some that don't progress from mild cognitive impairment to dementia. And so why do they not progress? Well, this could be because of different causes for mild cognitive impairment that are treatable, which is again why it's important to identify those treatable causes. And treatable causes including mood and sleep disorders, sometimes medications, and by medications that could be things like benzodiazepines that could cloud memory and thinking. It could be a lot of the bladder medications as well that are anticholinergic, as well as a whole slew of other medications that can cloud memory and thinking. Vitamin deficiencies and of course thyroid disorders are also among those reversible causes. Okay, so that question that about 50% of the room was wondering about, Alzheimer's versus dementia. So it's not about differentiating Alzheimer's from dementia. I want you to understand that dementia is like an umbrella term. And this umbrella term encompasses symptoms of dementia, with Alzheimer's being the most common. Alzheimer's is the most common type of dementia, with other causes after that, including Lewy body dementia, vascular dementia, frontotemporal types of dementia, and then other types, Parkinson's, Huntington's, and other rarer types. But what's interesting is recent autopsy results have indicated that about 50% of patients with Alzheimer's actually don't just have Alzheimer's alone. They have what's called a mixed pathology. So they have things like Alzheimer's plus Lewy bodies, as Dr. Dalvi mentioned. They also have vascular types of dementia. So it isn't just Alzheimer's alone, but for the sake of simplicity, Alzheimer's is the most common type of dementia. It's not about differentiating between the two. We determine the type of dementia by the type of damage and the regions of damage in the brain. So for example, in Alzheimer's, we have something called extracellular beta amyloid plaque, and we have intracellular tau tangles. And these are the hallmark pathologies that are most typically in Alzheimer's located in the temporoparietal regions. It gets a little bit confusing because Alzheimer's isn't always typical in the pathological sense. We can have all kinds of variants where these amyloid plaques and tangles that we'll talk about later can be located in different parts of the brain, therefore causing different types of variable presentations. And so these presentations may not be like your typical Alzheimer's, but may have the pathology of Alzheimer's. Moving on to our next slide. There were some eye-opening facts on here. So, more than 6 million Americans are living with Alzheimer's, and 1 in 3 seniors right now is dying from Alzheimer's or another dementia. Crazy, I think. And Alzheimer's and dementia, which we've seen in our clinic, dementia-related deaths have increased by 16% during the COVID pandemic. This is really unfortunate. I think a lot of our patients, unfortunately, are very socially isolated. They're not getting very much stimulation. Our patients that have or are in facilities, unfortunately, don't have access to things that are familiar to them, including close family and friends. And this, I think, is leading to, a more rapid progression of the disease and unfortunately death. And so these are some interesting facts I wanted to share. So when we're talking about risk factors for late onset Alzheimer's, and by late onset, I mean when symptom onset is generally over the age of 65. The best known risk factor is age. And unfortunately, we can't reverse aging. We can't stop aging. So you can't really do anything about this particular risk factor. But as you can see by the stats up there, risk does increase with age. Then you have genetics, which in this population above the age of 65 and late onset, the gene with the strongest impact is ApoE. This is a gene that regulates cholesterol. And so basically with this gene, you get one copy from your father and one copy from your mother. And there are three different variables of this gene. There's the 2 subtype, the 3 subtype, and the 4 subtype. The 4 subtype increases risk for Alzheimer's. So if you have one copy, your risk is slightly increased from the general population, roughly 25 to 30%. If you have 2 copies, we're looking at around 40 to 50% increase in risk. Then you've got family history as well, which increases risk. So number of first-degree family members that have the disease, meaning parents or siblings. The more first-degree relatives you have with this diagnosis, the greater the risk. Cardiovascular risk factors, so risk factors like diabetes, high blood pressure, high cholesterol, smoking, exercise level, alcohol as well, diet, all these things can influence as well. Educational level and cognitive stimulation, these are very important because we think that these build what's called cognitive reserve in the brain. Cognitive reserve is the brain's ability to make flexible and efficient use of cognitive networks and to basically reroute around the areas of damage. And you build this up throughout your lifetime through both education and hopefully through adequate cognitive stimulation. Traumatic brain injuries, the risk increases with the number of brain injuries. And so then earlier we mentioned biomarkers, and I was alluding to biomarkers of Alzheimer's disease. So I wanted to start off by talking about what a biomarker is. Biomarker is a biological change that can be measured that indicates the presence or absence of a disease or the risk of developing a disease. So for example, glucose in the blood is a biomarker of diabetes, but it can also predict one's risk for cardiovascular events or stroke for that matter. So glucose in this particular case example is a biomarker. Its utility in Alzheimer's disease, well, it's really important because as we noticed, there is that preclinical stage where patients are asymptomatic. If we could identify a biomarker earlier on, we could hopefully intervene at an earlier stage and hopefully delay or prevent onset of symptoms and possibly alter the trajectory of the continuum that I mentioned earlier. It's also important from a clinical trial perspective, like I said, because identifying certain biomarkers can help to really tag down a certain clinical trial that can target that biomarker and help to alter the trajectory of the disease. It's also critical for monitoring effects of treatment. Researchers nowadays are saying that future treatments really where things are at is stopping the progression of the disease earlier and earlier on. So we're really leaning towards mild cognitive impairment and preclinical stages of the disease to alter things. I wish I had that slide to show you, but on that curve, you could see that the curve for the continuum of Alzheimer's, it kind of started off flat and then it had this kind of drop off point, kind of like a roller coaster. And we've all, I think, probably been on a roller coaster in our lives. Where you get up that hill and you're kind of at this flat point for a while, and that's the mild cognitive impairment stage. And then you start to drop, which is the mild Alzheimer's stage. And then you hit this point of no return where no matter what happens, that roller coaster car is going down that hill, right? And that's how Alzheimer's is too. You get to the moderate stages and things start to roll downhill at a faster and faster rate, and there's less that we can do to alter the progression of the disease. So early intervention, I can't emphasize this enough, is very important. So I wanted to show you what a healthy brain looks like in terms of these neurons in the brain. And neurons are brain cells in the brain that have these long branches and that we call dendrites. And dendrites connect with one another to create synapses or connections. And there are about 100 billion neurons in the brain and about 100 trillion synapses in the brain. And then, of course, depending on how cognitively stimulated you are and your educational level, you may have even more synapses than that. But these synapses are really important because chemicals like acetylcholine deliver really important information that regulates mood, cognition, and behavior through these synapses. On the next slide, you see two different hallmark biomarkers of Alzheimer's disease. On the left-hand side, you see amyloid plaques. So you see those triangle-shaped or diamond-shaped neurons, and you see these puffy little areas that are kind of like cotton candy. And this is beta amyloid protein that has misfolded and is either an oligomer or even in its larger form, a plaque that is forming in between the neurons, outside of the neurons. That's really important because that's creating, it's affecting the ability of these neurons to communicate with one another. On the right-hand side, you see neurofibrillary tangles. I think I have a slide that highlights that a bit better. So again, on this slide, you see those puffy plaques that are forming outside of the cells, interfering with the ability of neurons to communicate information with one another. And on this slide, you have, it's kind of hard to see, but you have within the neurons, you have kind of like train tracks. And these train tracks are microtubulars. It's a complex system that helps to deliver nutrients and other important materials to the cell. The tau protein is another protein associated with Alzheimer's. And it's a protein that is typically present within these neurons that helps to kind of stabilize these railroad tracks and to keep them functioning. But unfortunately, when these become phosphorylated, they become unstable and they come off the tracks. And they form these tangles, like crooked little bobby pins on the inside of these cells. And that is another hallmark pathophysiology of Alzheimer's, which is tau tangles. So the train comes off the track, so to speak. Eventually, those tau tangles are excreted from the cells and they travel from neuron to neuron. And that's how we think the disease in later stages propagates itself. So some of you may have heard of the amyloid hypothesis, as some of you may have heard of the tau hypothesis. And of course, there's always this debate about which comes first, amyloid or tau. But I think right now we're leaning towards amyloid comes first with tau later on. And then of course, there's a whole bunch of inflammation in there that kind of acts as a fire fluid to drive the whole cycle forward. So those are key elements. On this slide, you see that there are these microglia. Microglia are cells in the brain that are basically like the garbage men of the central nervous system. They like to collect all the debris, including toxic proteins from dead and dying cells. And so when you have these plaques and these tangles and these dying cells, you start to see an increase in microglia. And, through a complex process, you start to see chronic inflammation as these microglia struggle to keep up with garbage collection, essentially, which is clearing these toxic proteins and the debris from the dead and dying neurons. So kind of segueing on to biomarkers in terms of how do we identify these biomarkers? Well, we know what they are, but how do we identify them? There are a couple of ways. So we have FDG PET scans. FDG PET scans are looking at glucose, which is tagged with the radioisotope. And we are looking to see how well these synapses, those connections, are taking up blood glucose, the main fuel in the brain to regulate cognition, memory, and other function. When we have areas of hypometabolism, the pattern of hypometabolism can point to different causes, whether it's Alzheimer's or other causes. And so you see an example of a PET scan on the right-hand side. where you've got a difference between the right, you've got the normal on the left, and you've got the Alzheimer's on the right. The blue and the black areas on the right may indicate the reduced activity from the disease. And then you've got amyloid PET scans, in which a radioisotope that is specific for amyloid is given through an IV. And we wait for a short period of time afterwards. And essentially, simply put, anywhere where there is amyloid plaque in the brain lights up red like a Christmas tree, like lights on a Christmas tree, I should say. And it's kind of hard to see because I didn't make this picture big enough, but you can kind of see the areas that are reddish looking in the Alzheimer's disease brain in the top row. And those are areas of amyloid plaque as visualized by an amyloid PET scan. And it's also important to know that 30% of normal older people will have a positive amyloid PET scan. And it doesn't necessarily mean that you're going to have Alzheimer's. And actually, there is a subgroup of patients out there that are what we call super agers that have amyloid in the brain, but are still sharp as a tack and do not have cognitive difficulty. So that's a possibility as well. Then we also have tau PET scans, same as amyloid PET scans, except that we have tracers that are specific for the tau tangles. And those will light up, and generally we should see more of a light up in the neocortex, which is the frontal lobe of the brain there. And then we have spinal taps. And so spinal taps are actually not as bad as one would think. You may disagree, but traditionally many spinal taps were done blindly without fluoroscopy, but nowadays we have fluoroscopy for adequate visualization, which is really important. Because unfortunately, when you're working with back anatomy that has changed over years and years of aging, things are not so easy when you're trying to get the spinal fluid from around the spinal cord. But this is really important because being able to withdraw that fluid and being able to look at those beta amyloid and tau levels can be really helpful in terms of making a diagnosis of Alzheimer's or ruling out a diagnosis of Alzheimer's, or even looking for other etiologies as well, infection and so forth. So moving on to current treatments that are available, there are FDA-approved treatments, and then that are symptomatic, and then there is one disease-modifying treatment that was just approved, Aduhelm. So as far as symptomatic therapies go, acetylcholinesterase inhibitors like Aricept, galantamine, rivastigmine, these are all approved acetylcholinesterase inhibitors, symptomatic therapies. However, it's important to know that there are no approved FDA treatments for behavioral or psychiatric symptoms in dementia at present time. And so this slide goes through and it kind of highlights donepezil, which came about in 1996. We've got rivastigmine and galantamine. These are all medications that increase acetylcholine levels in the brain, because we know that as neurons die in the brain, acetylcholine levels decrease. So these medications help to boost those levels, but it's important to notice that it may or may not improve symptoms. Some people may notice a change and some people may notice nothing at all. And then there is an NMDA receptor antagonist called memantine. And then most recently in 2014, we had Nimzeric, which was FDA approved or approved by the FDA. And this is a combination of Namenda and Aricept. And so on this slide, this is just reviewing again through the mechanism of action of these symptomatic therapies. So acetylcholine, like I said, when you have dead and dying neurons, you have a decrease in acetylcholine levels. Acetylcholine, bursts of acetylcholine are what help to regulate memory and cognition as well as behavior. So boosting those levels sometimes can be beneficial. And then you have memantine or Namenda, which works to block a receptor in the brain, the NMDA receptor, which is hyper-stimulated by higher levels of a damaging chemical, neurochemical called glutamate. Glutamate is another neurotransmitter in the brain, and with normal levels is good for memory and thinking. However, when it becomes toxic, it starts to overstimulate these cells, and when these cells are overstimulated, they start to die off. So that's how that works. And so overall take on symptomatic therapies, On average, the 4 approved Alzheimer's drugs are effective, we think, for about 6 to 12 months for about half of individuals who take them. You know, with that being said, when our patients come in for clinical research options, for example, we always give them options of being able to start a symptomatic therapy before adding on an investigational disease modifying therapy, because it may be helpful. I mean, the stats say 50% benefit. If it's tolerated, I don't think that there's any harm to considering it. But then really where things are at are with disease modifying therapies. And so some of you may have heard that the FDA just approved aducanumab or Aduhelm as it's being marketed. And there's been a lot of controversy about this drug produced by Biogen. But, you know, it is a monoclonal antibody that targets beta amyloid plaque. The thought is that it increases the clearance of this beta amyloid plaque and reduces levels, thereby not treating the disease, not improving the disease, but helping to hopefully stabilize or reduce the rate of decline in cognition and functional decline. It is the first FDA-approved disease-modifying treatment for Alzheimer's. And it was approved under an accelerated pathway in which the drug's effects on the biomarker, which was reduction in beta amyloid levels, was seen in participants. Clinical benefit will still need to be proven post-approval. So that means that pretty soon they're going to have a clinical trial, most likely double-blinded, placebo versus investigational treatment, aducanumab, in which they further look for clinical benefit through different cognitive assessments like the ADAS-Cog, the Clinical Dementia Rating Scale, and so forth. So interestingly enough, this is a really costly drug. Estimates right now are saying that the total cost of this drug yearly, just for the maintenance dose, just for the drug itself, is around $56,000. But then you have to think about all the other costs associated with it. So this includes safety assessments like MRIs, visits with neurologists, spinal tap showing presence of beta amyloid abnormal levels. So we're looking at $86,000 roughly, which is a lot. So currently, Medicare is hashing it out with Biogen, trying to figure out what reimbursement will be. I believe other private healthcare insurance companies will probably follow suit with whatever Medicare decides. But we don't really have a clear idea on what the costs of the drug are at this time. And then there is the possibility of obtaining similar drugs that work in similar ways or in other ways that are investigational that may be disease modifying through clinical trials. So, you know, I ask you, if you were diagnosed with a cancer, with an aggressive cancer, and there was a possible treatment at Sloan Kettering, there's probably a chance that you would consider going there. So what I want to say is that through clinical centers like ours at Brain Matters Research, we offer disease modifying therapies, and we're not that far of a drive away. Actually, we have a location here in Stewart, and we have a location in Delray where sometimes we have more clinical trial options. But I think it's something worth looking into. The benefits of clinical trials, you have the opportunity for disease clarification by identifying biomarkers with cutting edge technology. So you have access to things like the FDG PET scans we talked about, the amyloid PET scan that I referred to, which out of pocket is generally somewhere between $3,000 to $5,000 and not covered by Medicare or any other private insurances. You have access to things like a tau PET scan, which is not currently offered outside of research. And then for those of you who are brave and daring, you have access to CSF analysis through spinal taps. So these are all opportunities to clarify diagnosis and to intervene at an early stage. And I think you absolutely should take advantage of that. And so once a diagnosis is made, of course, you have access to other disease modifying therapies. So we have a few through clinical studies, including other monoclonal antibodies that clear amyloid that are currently ongoing at our site right now. And you never know, that could be the next drug that is approved. So Eisai and Eli Lilly, both other pharmaceutical companies, currently actually have applied for breakthrough status for drugs that they are marketing that are also anti-amyloid in nature. And they are still offering clinical trial options at sites like ours where you can participate and possibly receive the study drug at no cost and save your $86,000 and hopefully take a trip to Tahiti or something fun. So these are the advantages of clinical trials. But, you know, as with every presentation, I don't want you to have to process all of that and take all of that away from you, would take all of that away with you. But I think important points are early diagnosis and early prevention and early treatment are really important. So if you're not sure, get it checked out. Talk to your provider, come see us at our clinic. We offer free memory screens with a brief consultation with Dr. Brody or myself, 2 different neurologists specialized in memory disorders. At least if a clinical trial is not for you, we can always offer other solutions or at least offer basic recommendations and kind of set you on the right path. There is no cure for Alzheimer's. However, you can make a difference through research and through other lifestyle modifications. And that's pretty much it. I told you I'd keep it short and sweet.
Okay, let's see. Is my microphone working? Yes. I see some hands going up, but we're going to collect the index cards for questions, and we might have some questions on the chat box as well. I don't know, Adam, can you see if there's any questions that came in on the chat box? We'll check with that, but I do have a couple of announcements when those questions are getting gathered. Questa is picking them up. Laura Kramer in the white sweater, we co-facilitate the support groups that happen here on Zoom right now, and she brought her literature in. It's on the resource table in the very back of the room. She does individual counseling as well as other support groups and a Parkinson support group. And I had mentioned life care therapy before. Matt Green, can you please stand up for a second? Matt Green is going to be coming back. He's from Life Care Therapy. He will be teaching, or he will having some of his staff teach our Parkinson's class that is offered in a few months. We'll be resuming again. You can check here. It's typically on a Thursday afternoon around 3:30, but we'll do that. It's a free Parkinson's class. Let's see. Let me see if we can get any of these questions. And Dr. Patel, that was fabulous. Thank you so much. I learned a lot today from both doctors, I'll tell you that. Here's a Dr. Patel question. Glucose sounds important. Are processed foods dangerous? Fructose, dextrose, etc. Dextrose.
Yes. The simple answer is I think refined sugars have an addictive quality to them. I think if you can avoid them, that's better. Of course, when it comes to Alzheimer's disease and the best diet that you could follow, Mediterranean diet is the way to go. And of course, not part of that recommendation is refined sugars. So yes, glucose is bad. We know hyperglycemia can cause damage to brain neurons. If you can I can't tell you to not eat sugar, but I can tell you to stick to natural sugars as part of fruits and so forth. And ideally fruits that are also high in antioxidants so that you can get that benefit as well.
Excellent, thank you. And Adam, we'll be able to offer this recording on the canecenter.org website, right? So you'll be able to see people will be able to see the slides. They are on the Zoom. Adam did some screen sharing. Thank goodness for our IT genius over there behind it's like Oz over there. Thank you so much, Adam. So yes, you will be able to get Dr. Patel's statistics and Dr. Dalvi's information. Let's see, is there a typical age range for Parkinson's onset, Dr. Dalvi?
So typically, we will see onset of Parkinson's at age 55 to 65. Again, it depends on genetic factors. I have patients I've diagnosed in the 30s and 40s. Youngest ever I've diagnosed, as I mentioned earlier, was 17 or 18 at diagnosis. But for the most part, 55 to 65 is the typical age at onset.
Thank you so much. You mentioned high protein diet, clogging the bus stop. What foods are good for Parkinson's and what foods are bad?
So again, as Dr. Patel mentioned, the Mediterranean diet is one of the favored diets, and there's a modification to that called the MIND diet, M-I-N-D. So it's Mediterranean/DASH diet, which has been shown to be helpful in Parkinson's. With respect to the high protein issues, it's absolutely not a recommendation that you should not have protein. It's just in some patients, if they take their medication at the same time as meal times, the protein in the food can reduce the absorption of levodopa. And for those patients, we recommend they take their levodopa in particular an hour before meal times or 45 minutes before meal times. But it shouldn't be construed as a recommendation to avoid protein, because otherwise you will have malnutrition, and that's not recommended.
Thank you, doctor. When taking Aduhelm, should other meds like Nemzaric be stopped? Are considerable improvements, have there been considerable improvements in patients?
That's a very good question. I never recommend stopping a symptomatic therapy per se, especially if it is one that is tolerated. I would say that, like we said, there are two different categories of treatments. There are symptomatic and disease modifying. It's okay to be on both, especially if we're tolerating both. Speaking on the second half of that question in terms of Aduhelm, we have been working with this particular drug at Brain Matters Research for the last at least 5 or 6 years. We have seen in patients, especially those that are earlier on in the spectrum in both mild cognitive impairment and even some of the mild Alzheimer's patients, we have seen stabilization where there aren't significant changes over time. And we measure this with serial cognitive assessments. That being said, I can't honestly say that I've noticed those same differences in the moderate and the severe stages, because like we said, at some point the disease kind of spirals out of whack, and it's very difficult to stabilize at that point. But we have seen stabilization, and we have seen slowing of decline in the earlier stage patients.
That's exciting.
It is.
We like hearing that. Is vertigo part of Parkinson's?
So unsteadiness is part of Parkinson's, because the fourth symptom in Cardinal Symptoms was posture and gait changes, which can include unsteadiness. When you say vertigo, you're typically referring to a sensation of the room spinning round or some similar sensation. Very often in the same age group that has Parkinson's, the vertigo comes from something called as benign positional vertigo. But I think it is important, if you're having vertigo, to actually get an imaging study, because a stroke in the back of your brain, it's called a posterior circulation stroke, or a tumor in the back of your brain in the cerebellum can also cause vertigo. So to get that worked up with a brain MRI, or at a minimum, a CT scan is important.
We are so appreciative of the expertise of both of you. And I have a few more questions, but thank you so much. I am learning from every question. Are there clinical trials for advanced Alzheimer's disease?
There are, and we currently don't have any at Brain Matters Research, but if you look on a website called clinicaltrials.gov, this is a website that goes through all of the current ongoing FDA-approved studies. And yes, there are some, particularly for behaviors. Actually, I take that back. We do have one study that is for apathy, which could involve patients that are later on. And apathy is, of course, that difficulty with initiation of tasks and activities. So we do have that, and there are trials out there. But again, the emphasis more recently has been a focus on earlier and earlier stages of the disease, which is really unfortunate for those in the moderate and severe stages. But clinicaltrials.gov is the website that you want to look on if you're looking for that particular topic.
Thank you so much. Can you make a diagnosis of Alzheimer's with a negative amyloid PET scan?
You can't make a diagnosis of Alzheimer's with a negative PET scan, but depending on the clinical scenario and depending on the clinical history, a negative PET scan may rule out Alzheimer's at the time. And then also things actually do get kind of sticky, especially through research, because different studies have different thresholds for what they consider positive for amyloid PET scans. So sometimes the study will report to us that you have a positive or you have a negative amyloid PET scan, but it doesn't necessarily mean that you don't have amyloid. It just means that the negative is just indicating that that the amyloid is not enough to meet what the study is requiring as their basic threshold. And so it's really individual dependent, and each scenario is different, and you really have to take the clinical scenario into account with the amyloid PET scan results. And that obviously is best done through a neurologist.
Are there other biomarkers you're looking for with Alzheimer's?
There are other newer biomarkers that are being looked at. A lot of inflammatory markers are being looked at, both in the blood and the spinal fluid. But of course, amyloid and tau are the big players in the game right now that are being looked at as hallmark biomarkers of Alzheimer's.
I have a feeling this one is going to be for Dr. Dalvi. How does DBS, deep brain stimulation, improve dysphagia symptoms in patients with Parkinson's disease?
So deep brain stimulation actually is targeting an area in the brain that is the size of a little larger than a tic tac. But in that area, it is including information literally from the entire homunculus, meaning the part of the brain that controls the face, the upper extremity, the lower extremity, the whole homunculus. Part of that is the swallowing mechanism, which involves swallowing reflexes. So even though DBS is not designed to improve swallowing, this is something we've seen time and time again, that as an incidental benefit, patients after DBS are able to swallow better. We also will see another symptom which we really don't plan on improving, but many patients will say, I used to have a lot of back pain. I thought it was sciatica, but now I had deep brain stimulation and now my sciatica is gone. And that again is because deep brain stimulation reduces the dystonia, the muscle cramping, and that gives the patient relief from back pain, which they had until that point thought was related to disc disease in the back or sciatica or some such. But having said that, DBS per se is not designed to be a treatment for dysphagia.
Oh, and then another part of that is, as what stage of Parkinson's disease does that dysphagia?
Stages of Parkinson's disease are not like stages of, say, cancer treatment. So it goes stage 1 to stage 5 based on whether your symptoms are one-sided, both-sided, whether balance is affected, whether the disease is advanced, or whether you're wheelchair or bedbound. Those are the 5 stages. But really, different symptoms can happen at different stages. Some patients might present with tremor when they're stage 3 and not had tremor at stage 1 or 2. Some patients may have trouble swallowing at stage 1. Some may not have trouble swallowing at stage 5. So there's not so much of a one-to-one correlation between different symptoms and stages. Having said that, generally the swallowing reflexes, usually you're looking at patients who are towards the end of stage 2, beginnings of stage 3 in Parkinson's.
Thank you. And I'm looking at the clock now. So we have a lot more questions, but one more question. What causes restless legs?
So restless leg syndrome is, again, a dopamine problem, but more than likely it affects a dopamine system in the brain that is not related to Parkinson's. When you say dopamine system in the brain, you're looking at D1 all the way through D5 receptors. In Parkinson's, D2 systems are involved. In diseases like schizophrenia, they have too much activity in the dopamine levels at D3. In patients with restless leg syndrome, it might be D1 receptors that are involved, but clearly it's part of the brain that is different from Parkinson's disease. Having said that, treatment for restless legs, some of the most successful treatments are very low doses of dopaminergic drugs, which are called as dopamine agonists, like Mirapex or pramipexole or rotigotine, which is available as a patch.
I want to thank you so much for that. Thank you for the information. I know there's more questions, and we probably have questions on chat that we didn't get to, but I have exactly 3 o'clock. We have some door prizes to give away. I want to introduce Tequesta. If you haven't met Tequesta Alston already, raise your hand. Tequesta over there by Adam and our IT setup over there. And Thank you so much she's from Brain Matters Research. We appreciate all your help and knowledge here today as well. And we thank everybody for being here. Either of you, would you like to make a closing comment before I do the door prizes? Or both of you?
No, I just thank you everybody for your attention. I know it's been tough paying attention to both presentations back to back, but thank you for being here and thank you for your attention.
I would just like to close by saying that 2020 and 2021 will not rank among my favorite years. I don't think they will for anyone. Having said that, the progress we have made on the research side, especially with developing some of these new technologies, with bringing the focused ultrasound trial right here to our community, it's happened through the pandemic. And I think as things open up a little more, we will continue to make progress along these lines. So in that sense, I'm really optimistic for the later part of 21 and certainly for 2022. Wish you all the best for that next year.
We like that.